Hello, Kidney Warriors. James here from Dadvice TV, your online kidney health coach, and this is Dadvice TV Live. Now, for those of you that are new, welcome. Great to have you here. My name's James, and I, like so many of you, am a kidney warrior. I was diagnosed with stage 5 kidney disease, and instead of going on dialysis, I have focused on what I can do to help reduce the burden on my kidneys, live a heart-healthy life, because that's very important for those with kidney disease, and help keep all of my symptoms at bay, which allows me to continue to enjoy life while not needing dialysis at this point in time. Now, tonight, we are going to talk about an incredible topic that's so important. We're going to be talking about protein urine, the protein that's leaking into your urine. And we've discussed in the past why that is such an important thing to watch, because it's an important indicator of future kidney issues. But we're going to talk about what you can do to help reduce the amount of protein you're losing, that you're leaking out in your urine, and what you can do to help slow the decline of your kidney function. Now, to do that, we are going to talk with one of your guys' favorite hosts right here. Please welcome here with me, Dr. Steven Rosansky. Hey, Doc.
Hey, James. Good to be with you. I hope you got that fly out of the way, because I was waiting for it to land on your nose.
So that everyone knows, the doc and I were talking before we started, and a fly got in my office, and it's zooming all around. And I was like, okay, I got to get rid of this fly before the show starts. I don't want it landing on me.
Yeah.
Now, can you introduce yourself for those that are new? Maybe that's their first time here.
So I am a kidney specialist, practiced nephrology for over 40 years. I've taken care of hundreds of dialysis patients and other kidney patients. I've also done a good bit of research, and have been recognized for my research in the area of the issue of when to start dialysis and the things that affect progression of kidney disease. I've written a book for you folks about kidney disease, and hopefully that book will help you alleviate some of your fears and anxieties, help you slow the progression. And for those of you who are unfortunate enough to need dialysis, to not get started on dialysis too early, which is one of the main areas of research that I've done to show that starting dialysis early may actually be harmful. So I recommend you read the chapters related to that and the other chapters in my book. And we're going to talk about something which I feel is very much unattended to, and it's the issue of protein in your urine, which is, if you can decrease, I'm going to repeat this several times tonight. If you've got significant protein in the urine, and if you can decrease that protein in the urine, that is the best way to slow the decline of your kidney function. And we're going to dive deep into it, and hopefully you'll all understand what that protein means. I also have published about 100 papers, peer-reviewed papers, and I am retired, but I practice. I do nephrology in the free clinic in
Yep.
Columbia, South Carolina.
Yeah, and I want to do one quick plug for your book. You did mention it, and I showed it up on the screen. But for those of you that are diagnosed with kidney disease, there's so many unanswered questions that we have. There's the fears, there's all sorts of anxiety, and we end up going to the internet and finding all sorts of stuff. A lot of stuff that Dr. Rowe and I call woo-woo. That's all those fake cures and fixes and stuff that aren't going to fix things. It could actually make things worse. Dr. Rowe's book is so easy to read and to understand, and it addresses so many things that a newly diagnosed kidney patient has questions about. And chances are your nephrologist didn't have time to explain them, or they may have explained them, but you're sitting there taking in so much information, you didn't hear everything they said. So I do want to encourage anyone who hasn't gotten a copy of it, go to Amazon.com, go to your local bookstore, pick up a copy of his book, Learn the Facts About Kidney Disease. This is, in my opinion, the #1 book for all kidney patients. And if I could do one thing that I know would help everybody with kidneys around the world, it would be that when you were diagnosed, a doctor handed you a copy of this book and said, hey, read this, then let's talk about it. I know you're under a lot of stress and worry right now. It's not going to be that bad. We're gonna work on this together. And they'd give you that book. So I wanted to get a quick plug in there for it. A lot of people watching have read your book, and they always have great things to say about it. So let's get down to urine protein and what we can do to reduce it and slow the progression of our kidney disease.
So let's repeat it. Proteinuria, and we're going to define it in a little bit. We're going to dive deep into it. I want you to understand it is the best predictor of the future decline of your kidney function. And it should be the main goal of treatment. Reducing the protein in your urine should be the main goal of treatment. And I think too many of my colleagues, and certainly in the general medical area, they're not aware of it. And many patients don't even get their urine protein checked, which is terrible. And we're going to tell you how simple it is. And I'm going to actually tell you how you can get your own test for your urine protein on Amazon, which if it were me and I had protein in the urine, I would want to have them. There's way too much focus, as we've talked about on this show, over and over on your EGFR. Your EGFR is fairly meaningless for the most part. Everybody says, oh, there's all these different cures and things I can do to change my EGFR by a couple of points. That is absolutely meaningless in the big scheme of things. But if you can reduce your protein in the urine, especially if you have significant amounts of protein in the urine, then you've done all you can to slow the progression. And remember, that EGFR number is not a real number. That number could be plus or minus 10 or 20% easily. So don't let anybody tell you and give you these testimonials about woo-woo things or protein, low protein diets with supplements, which are dangerous, which can actually give you malnutrition, and change your EGFR by a few points here or there. That's meaningless. Lowering your protein, if you reduce protein, and this is in many, many studies, reduction of protein in the urine has invariably been associated with a better outcome for you. And it will help protect you from a decline of your kidney function. And it also will protect you from the hardening of the arteries related to decline of kidney function. And it is the most important modifiable risk factor for your kidneys. I mean, there's a lot of risk factors that we talked about in lifestyle, and they are all important for longer life. But the risk to your kidneys, the protein is the most important. And if you can get that urine protein down, the studies have also shown consistently that it will decrease your risk of dying from hardening of the arteries. The term that James loves, atherosclerotic cardiovascular disease. Well, all that means is strokes and heart attacks and decreased blood supply to your brain, to your legs, resulting in amputations and stuff like that. Heart failure, all the bad things that come from the risk factors that relate to progressive hardening of the arteries and cardiovascular disease. So let's get into what levels of protein matter. And many questions, and by the way, I will thank your audience for this talk, because we've had several talks and some of your questions came up and they actually showed me that I needed to get clarification for you about these levels of protein in the urine and what matters. So not all levels of protein matter. There's something called microalbuminuria, and the protein in the urine that we're going to focus on is a protein called microalbumin. Now, James, have you heard of microalbuminuria? You may have
Yep.
heard of it. Okay. Well, I can tell you this. I've been involved with a lot of research studies. I was involved in a lot of the drug studies. And we're going to talk about the ACEs and the ARBs. We'll get to that later. I was involved with the research studies on the ACEs and the ARBs. And to qualify, you had to have microalbumin. What is microalbumin? It's a low level of urinary albumin. And in general, that has a correlation to the risk of the hardening of the artery stuff, the low levels. But when you get up to having 200 to 300 milligrams of that albumin in your urine, that's when you get to the level when it's strongly predictive of progressive kidney disease as well as dying from cardiovascular causes. And that level, again, is somewhere around 200 to 300 milligrams per day. And we're going to tell you best ways to measure it. And having that level of protein in the urine has been shown over and over again as a strong predictor of developing a need for dialysis or transplant in the next 10 years. A lot of you have asked, and James has talked about this on other shows, about what's your risk of needing dialysis or a kidney transplant. I have a chapter in my book where I go over ways to predict it, and you can take this chapter, go over it with your doctor, and plug in your particular information to get an idea about your risk. And I'll tell you something, the most important factor in all of these predictions is urine protein. Big factor. So let's get down to basics. How does protein get into the urine? I'll refer you again to my book. I have a kind of not a great picture, but there's a picture of the nephron, which is composed of the what, James? Do you know what's in the nephron? The glomerulus. Are you talking? I can't hear you.
I had a mute on. Yeah, glomerulus. I had that right.
I thought you wanted me to read your lips. It's the glomerulus, which is a bunch of these little tiny capillaries, little tiny blood vessels, balls of blood vessels. That's the glomeruli. And the glomerular filtrate, the EGFR, glomerular filtration rate, how fast that filtrate's going through, right? That filtrate goes into tubes, these tubules. So you have the filtrate going into the tubules. So the parts of the kidney are the glomeruli, the tubules, and the tissue around the tubules, which is called interstitial tissue. And so the filtrate is generally going to not allow, it's got holes in it. Picture those capillaries of having tiny little holes. And if you've got a protein, we're talking about protein tonight, that is small enough, it might get through the holes. So there are certain proteins, and I'm going to throw out a number, that weigh 20,000 units. These are like units for molecular weight. Some of them can get through the holes, and some of them get reabsorbed. You don't have to understand all of this, but I'm going to give you a big picture. So when they get filtered, some of those smaller ones can get reabsorbed in the tubules. But the big guy is the albumin. That's around not 20,000, but 65,000. It's really big. It's a big molecule, and it has a charge. So it's a negative charge. So things that are negative to negative are going to oppose it. So between the charge and the size, not much gets through those glomerular capillaries. So you've got to have sick glomeruli to get those proteins leaking out of the glomeruli, and that's glomerular proteinuria. And that is what is the most important part of the glomerular diseases. And diabetes is one of the big glomerular diseases. And we're not going to focus much On the small proteins, the ones that are normally filtered, um, and there is a small amount of protein in your urine from those small proteins that get through. But we're mostly interested in the bigger albumin, and that's the biggie, and that's the one that we're going to focus on. So, how do you measure this urine protein? And there's an enormous amount of confusion, and I can't blame you. And I'm going to tell you why there's so much confusion. Okay. Um, again, over 300, and I would say even over 200, between 2 and 300 is when per day, 300 milligrams of albumin per day is when you got the bad outcomes. When you're dealing with, 30, which is the microalbumin, 30 to 200, let's say, that level is probably not real worrisome, although it may have some relationship to your risk of hardening of the arteries and bad outcomes from that deal, from atherosclerosis. Now, if you're going to go by the dipstick, which is an easy thing, and you can buy them, and I'll tell you the name of one that you can get on Amazon. There's a couple things to keep in mind. Firstly, your urine can be very concentrated or very dilute. Very dilute urine would be like water, like James is drinking. And the way you'll know, and if you buy these dipsticks, there's a line on the dipstick called SPGR, or specific gravity. Tells you how concentrated that urine is. And it'll go from 1, which is about water, to 1.030. Okay, that's real concentrated. And keep that in mind if you do look at your urine protein, and if you're in the middle around 1.01, 1.02, it's probably just average, all right? If you are like 1, you may be making several liters of urine a day. Okay, now try to follow this. Like if let's say you just got a real dilute urine, you could be making 2, 3, 4 liters a day. Who knows? And the way these dipsticks are measuring, and the latest ones make it easy. The ones that I grew up with, we were using deciliters, which is confusing as heck. A deciliter is 100 cc's, or a tenth of a liter. The new dipsticks don't deal with that. They tell you the amount of protein per liter. Make it a lot simpler. Okay? And traced is if you get a trace on a dipstick, it's in the microalbumin range. It means something that you should monitor, but not something that means you're going to have a high risk of progression. If you go to 1+, that is the 300 milligrams. If you are consistently 1+ or more, you got real protein in the urine. Okay. Now, I want to take it back for a second here, because if you're 1+, it will be 300 milligrams per liter. But let's say that you're making real concentrated urine. You're only putting out a half a liter. You could be making not the 300, but only 150. Does that make sense?
Yeah. Okay. So if I'm dehydrated, I'm not producing as much urine, and it is more concentrated. And if I'm overhydrated, I drank maybe lots of water, it's being diluted. So if I had, I got to kind of take that into consideration.
It's not a question of diluting the test. It's a question of how much the test is telling you that you're putting out. Let's say 1+ is 300 milligrams. If you make a liter, if you make 2 liters, that would be 600 milligrams. 3 liters would be 9. So if you're producing a dilute urine, you may be making several liters. On the other hand, if you're producing a concentrated urine, you may only be making a half a liter or less. So you may not be putting out 300. You may only be putting out 100 or 200. So 1+ can mean significant protein depending upon dilute or concentrated. On the other hand, when you get to 2 plus, that is 1 gram per liter. So if you're 2 plus, you're probably in the high range. Because if you're putting out 1 gram of protein per liter and you're only putting out a half a liter, that's still 500 milligrams. You got serious protein. 1 plus, not absolutely sure. 2 plus for sure. 3 plus goes really bad because it's 3 grams per liter. That's way up there. And 4 plus is way, way, way up there. Okay. So this is just kind of a ballpark way to get, the level of the protein in the urine. And like I said, you can buy the dipsticks for specific gravity, for pH, for protein, and also to test for infections in the urine, etc. You can buy them on Amazon. Now, not everybody that has a positive urine protein test needs to worry. You could have false positives. Here's what can give you a false positive. The commonest one is if you have a high pH in the urine, and the dipstick will measure the pH. A high pH would be 8, and that could give you a false positive. If you're cleaning your privates off with some of that usual cleaning compounds, that can give you the false test. So there are ways to give you false tests, and I'm going to talk about other situations where the protein is not to worry. Okay.
Now a quick question. Are these separate tests I would do at home if I was testing it? Test my pH, test my...
All on one dipstick.
Okay, great.
One dipstick tells it all.
Oh, fantastic.
It's got much more information than you're ever going to want. But it will tell you if there's blood in the urine. It'll tell you the pH. It'll tell you if you got an infection, white blood cells. But for our purposes, the focus tonight is going to be on the protein and on that specific gravity, because that's really what's the key for progression of kidney disease, is how much protein in the urine. Now, there is a more accurate way that your doctor will do to test the protein in the urine. Take a sample of the urine, send it to the lab, and they'll measure the albumin and they'll measure the creatinine in the urine. That is the best way to do it. And it's a reliable, accurate way to get it. And that ratio will, again, tell you about how much albumin you have in the urine per gram of creatinine. And anything over 300 is to worry, okay? And we used to do 24-hour collections. I think James can tell you how much fun that is.
I did it once while working, and you have to store that in the fridge. Not a good thing to do.
Yeah, and I will just tell you, because you may have been asked by your doctor to do a 24-hour urine test. I'm going to tell you how to do it. It's kind of simple. What I tell my patients is, if I send you home with a big jug to do a 24-hour urine test, I'll tell you to start tomorrow morning, pee into the toilet bowl tomorrow morning when you get up. Then collect all the urine for the entire day, plus the next morning's urine, and then you're done. You got it?
Yep.
That's how you do a 24-hour urine. Okay. Some labs report protein to creatinine as opposed to albumin to creatinine. I don't want to confuse you. I think the more important one to follow is the albumin to creatinine ratio. Remember, there are other proteins in the urine, I told you, besides albumin, but that's the most important one when we talk about progression of kidney disease. Now, the units drive me crazy. They drive me bananas. And I'm going to tell you something funny. We in the United States, we are so out of it from the rest of the world in the units that we use. We don't use the metric system. This is just so bizarre. And you know the countries that follow this crazy system? Liberia, Burma, and the United States. I mean, we are just out of it. We are just, we have United States customary units. That is so ridiculous. and and we've got inches, feet, yards. We don't have the metric system. We have miles instead of kilometers. We are just off the chart. But
We
anyway,
like making it more difficult.
it makes it much more difficult. The rest of the world, and a lot of you outside of the United States, you use the SI, the System of International Units. This is the most widely held system of measurement. And most scientists agree we should be using SI units. As a matter of fact, when I sent my book out to my colleagues in Australia, they pointed out, hey, Steve, your units are not going to be understood. So what we have in our country, and I hope I can finally get this straight for you because I know it's confusing as heck. We have the units of milligrams of albumin per gram of creatinine, and over 200 or 300 is going to be serious, significant. What you have is milligrams per millimole in the rest of the world. How do you take our units? Divide it by 10. So the 300 would be 30 milligrams per millimole in the rest of the world, over 30 milligrams per millimole, which would be a protein level in the urine to be concerned about. And just like your EGFR, as I've said a few times, and James probably knows this, one of the best ways to cure your kidney disease is repeat your lab test. and I can't tell you how many people have an abnormal EGFR, and when we repeat it, it's normal. And again, to be diagnosed with kidney disease with CKD, you need to have an abnormal value twice in a period of more than 3 months. It's got to be less than 60. This is the current thinking, because numbers over 60 are unreliable. It's got to be EGFR less than 60, repeated at least twice over at least 3 months. Okay. Now, there are what's so-called benign causes of having protein in the urine. Common thing, if you're sick, you have fever, you go to the doctor, you may have protein in the urine, not due to your kidneys. If you've exercised intensely, you may get protein in the urine, again, not due to your kidneys. Sometimes severe dehydration may cause some protein in the urine, even emotional stress and any acute illness. So just like EGFR, I recommend that you get serial tests of urine protein. And I think those urine dipsticks, if you happen to have protein in the urine, would be a great thing. They're like $16. I think it's a good investment.
Now, how far apart do those tests need to be?
Look, I think just like you need to diagnose kidney disease at least 3 months interval, you don't need to do your urine protein, every week or every day. Certainly not. Doing it every few months would be fine. And if you are trying to see if some of the treatments that your doctor is giving you, and we'll discuss those in a minute, are affecting your urine protein, you could check it every couple months and see what the trend is. And that's exactly what any good kidney specialist should also be doing, looking at the trend of your urine protein to see whether it's going in the right direction, which would be going down. Okay. Now, there is a very relatively common, another benign cause of protein in the urine, found in about 5 out of 100 young men and women in the military. They found this. I don't know if you heard this, James. It's called orthostatic proteinuria. Orthostatic means standing up. So these folks will have protein in the urine when they're upright. And when they're laying down, they don't have it. So that's a common benign cause of protein in the urine. And to really test for that, you have them collect urine all day and then all night and just see what the deal is. It happens in about 5 out of 100 people. No harm, not related to any kidney damage. Any questions so far before we talk about how this protein can hurt your kidneys?
I think we are ready for the next part. I want to make sure we have plenty of time to cover everything.
Okay. And I see we got a few questions. How does urine protein hurt your kidneys? Unfortunately, we don't know. I'll give you some thoughts. That protein that's coming through may worsen blood pressure, may worsen your cholesterol problems, may cause volume problems. I think the most likely explanation is it's directly toxic to the kidney itself. That's what I think is causing the kidney to scar and cause the glomeruli to die. But we actually don't know for sure why protein is harming your kidneys. But we do know that if you can reverse it, and if you can keep that protein level in your urine down, we can protect you from losing your kidney function. And this is not for all kidney patients, because there are other types of kidney disease where there isn't a lot of protein in the urine, and like things like the older folks can get progressive kidney failure slowly because, again, protein in the urine correlates with with faster loss of kidney function. But you can get decreased blood flow to the kidney or high pressures to the kidney from high blood pressure, and that can also damage the kidney and cause progressive kidney failure. Hang on one second. I got my hearing aids in, and my phone is in the other room. Excuse me, just 1 minute. While this,
no problem, Doc.
Oh boy, yeah, I love my hearing aids because I can listen to my phone, my podcast, my music, but also if someone's calling me, that's okay. I hope they don't call back.
Yeah, my dad's hearing aids are connected to his phone, which is great. Though sometimes he'll be talking, and I can't tell he's talking on the phone.
Yeah, I'll tell you, it's nice, but it's loud. Okay, so again, reversing that protein in the urine can really be a good sign that you're going to hopefully save your kidneys from failing. On the other hand, if you got increasing levels of urine protein, and we can't get that urine protein down. And there's lots of treatments, especially for some of the glomerular diseases that are proven by biopsy. There are treatments beyond what we're going to talk about tonight, including immune treatments and steroids and so forth. We try as hard as we can to get that urine protein down. If you can't, and it's very heavy, the likelihood is that you're going to go into kidney failure. So it's important to do everything we can to get that protein down if we can. And there are drugs that can help reverse this. And we've talked about the two classes of drugs that have been shown to slow kidney progression and decrease that urine protein. And it's especially for diabetics, but it also applies to non-diabetics. And those drugs are, and we're going to list them right now. James, go ahead.
Well, they are ACEs and ARBs.
Good.
Which are blood pressure medications. And I can't remember which ones end in pren. I can't remember which one's which.
Okay. The ones that end in pril are the ACEs, like captopril, enalapril, benazepril, okay? Those are I think they're all the same. And by the way, anytime you're using an ACE or any other blood pressure medicine for blood pressure control, it's important to use it with a diuretic. And a lot of these are coming with a diuretic, a low dose of HCTZ, hydrochlorothiazide. That's the ACEs, the ARBs, James. What's the ARBs?
I cannot remember which ones those are.
The ARBs end in TAN.
Dan. Losartan.
Yes,
That's a popular one.
that's right. Okay. So the difference between the ACEs and the ARBs, they do the same thing. They will both slow progression of kidney decline. They will both decrease protein in the urine. And if they are decreasing the protein in the urine, they will correlate to slowing your kidney function decline. They've been around over 20 years. And the sad part of it is only 1 out of 3 people that need them are getting them. And we need to get any of your patients who need to be on ACE and ARB to be sure that they talk to their doctor about getting them on an ACE or an ARB. And it's been shown, get this, James, that ACEs and ARBs can decrease kidney failure by as much as 50%.
Whoa.
So these are extremely important. And this is whether you're diabetic or not. And we're talking about the proteinuric patients. If we can get you on these ACE and ARBs, they really have an important contribution to slowing your decline. If you're in the, again, 200 to 300, certainly over 300 milligrams of that albumin per day, or the 30 milligrams per millimole. This is albumin creatinine ratio. 300 in our crazy US units and over 30 in the rest of the world. If you have that level of protein in the urine, even without high blood pressure, James, you should be on an ACE or an ARB, even without high blood pressure. If you happen to have high blood pressure and you have lower levels, let's say you've got the 30 to 300, the trace to 1 plus. If you're hypertensive, you should be on them. People that do not have protein in the urine, it's not as critical. On the other hand, ACEs and ARBs will have a benefit for people that have any kind of cardiac condition, because they've been shown to improve survival for patients with various types of cardiac conditions, including heart attacks and heart failure. But from the kidney point of view, if you, even without high blood pressure, you got that over 300 or over 30, you should be on an ACE or an ARB.
Hey, Doc, got a great question here from Mary. Does it matter what GFR you are?
A great question. And let's address that in 2 parts. The first thing is there is a lot of fear by a lot of doctors that are not real sophisticated with kidney patient issues, that if they use one of these drugs, they're going to raise potassium. And everybody gets very scared about elevated potassium. And certainly, if you go on an ACE or an ARB, you got to be monitored. You got to get your potassium checked. And the other part of the answer is you've got to get your eGFR checked, because it is commonly seen that when you start an ACE or an ARB, kidney function can go down by as much as 1/3. And the experts, and this has been discussed over and over again, the kidney experts agree that that's not a reason to stop the ACE or ARB. They're that important in the proteinuric patient that you continue them. Now, if the creatinine continues to go up, if the eGFR continues to go down, obviously you got to stop them. But they can be used for every stage of CKD with appropriate monitoring of eGFR and potassium. Great question. There are other things to lower urine protein. And next talk, we're going to talk about some of the newer drugs. But the things that you can do that may benefit lowering urine protein is lower your salt intake. That's been shown to lower your urine protein. You can overwhelm these good drugs by taking in a massive high salt diet. Um, statins, the things we use for cholesterol, may have some benefit to reduce the protein that you're spilling. Um, if you stop smoking, smoking ruins everything in life. It certainly, gives you heart disease and lung disease and lung cancer, but it can also affect your urine protein and accelerate your kidney loss. And if you control your diabetes, there's been some evidence that that can also help uh, lower your urine protein. The next talk, we're going to talk about the game changer drugs. I think James had another good, I think, a nephrologist on to give a talk on it, but I will give you some more updates on these, what I call game changer drugs. They're real big for kidney patients, for diabetic, and even anybody with heart failure. The so-called SGLT2s
Mhm.
and the GLP-1s and mineralocorticoid antagonists. And in the future, now one of the problems, as we will discuss next time, these drugs are expensive. They will get cheaper. But my guess is that we're going to have combinations of therapies that will lower that urine protein and give a lot of your patients, a lot of you folks out there, a much better shot at preventing you from going on to kidney failure. And next time when we discuss these new drugs, I'm going to discuss the latest stages. The staging system now, it took a long time for the kidney docs to realize that some of the staging stuff was not useful. And now they've combined the stages of EGFRs with the urine protein. And we're going to show you just how important that urine protein is when we look at the new ways to stage your kidney disease.
That is great to hear because I quickly learned how pretty much useless the stages are for me as a patient to help me in managing my disease or knowing what to do or predicting outcomes.
Well, yeah, and just to quickly review, there is no real stage one or two. I mean, basically, if you have over 60, that number is very unreliable, EGFR, and it is kidney disease if you have protein in the urine, and you can have protein in the urine with an over 60 kidney number, and that could be a significant concern. Okay. And so what the kidney docs finally figured out some years ago is that to talk about your stage, you need to know not just what your number is, but what your urine protein is. And that's a much better way to predict what kind of problems you may have in the future. So I've got some time to answer questions. And if you got any questions, James, why don't you start with you? What are the questions you have?
So I'll tell you, there are a ton of questions out here. This is probably one of our most viewed live shows that we have had. We've got a massive audience. I did mark a few of them. Um, does the time of day matter when you take your urine test? Say you're doing the dipsticks. Oh, and don't forget to tell us about which ones to get on Amazon.
Okay, yeah. Well, the Amazon, let's see, I wrote it down here somewhere. The Amazon,
Because I'll add a link to it in the description. I've got my Amazon account up here.
yeah, yeah, yeah. James, I'm going to give it to you after the show. But the main thing that you folks out there need to know is that there are various dipsticks, and there are some that just test for infection. Uh, it's called reagent strip for urine analysis, but make sure the strip has the blood test, the pH test, the specific gravity, and certainly the protein. It'll have all of them plus some other things on the strip. Now, as far as the time of day, that's a great question. Um, my in my training, we were told to do the first forwarding sample in the morning. Um, but I think that it really doesn't matter because you're going to go to your doctor's office. You may go in there fasting. there may be some difference in the test if you did it first thing in the morning, because you may have a more concentrated urine. Okay. I just think, like EGFR, repeated testing is the best way for you to get a good handle on what the status of your kidney disease is, whether it's your urine protein or your EGFR.
Very good. I'm sitting here trying to find all the strips.
Okay.
I'll look for those later. Let's see. What other questions? Someone had a question about your book earlier, Storm Vet. Would your book be helpful for someone who has IgA nephropathy?
I think I do not discuss the many glomerular diseases. There are a large range of glomerular diseases. But I will say this, regardless of what glomerular disease you have, whether you have, I'm just going to rattle off a few names, whether you have IgA, whether you have membranous, whether you have minimal change disease, whether you have membranous proliferative, whether you have focal sclerosis, the level of protein in the urine invariably is the most important factor. And depending upon the disease, there may be certain treatments that go beyond the drugs we're talking about. No, I don't go into them specifically, but for any type of kidney patient, all the issues are relevant. And I will say that there's ongoing work on IgA, and there are some new medications they're using. But for the most part, it's people with IgA and a lot of protein in the urine that are candidates for these new medicines.
Now, can a reoccurring UTI cause high protein?
You can get protein in the urine with UTI. You can get protein in the urine with infection, and you should repeat it when the urine infection is cleared up to make sure that it's real. Dolly has EGFR of 89, 46 years old. Do I have kidney disease? Dolly, again, that 89 may not be a real number. And like I said, a lot of labs are reporting it as over 60. So I think, for your age, that number is probably close to what it should be. But I don't think that 89 is an exact number, so I wouldn't even go by that. And urine and Myra says urine protein should be less than 300. Yeah, I mean urine protein should be less than 30, and if it's if it's between 30 and 300, it could be considered something to watch, not something that's really a high risk, but it's certainly something to watch. And how low to get the protein in the urine? If as low as you can get it. And I mean, it's rare to see a true remission. In other words, go from having a gram of protein to going down to 30, let's say 30 milligrams or something like that. But my guess is in the future, with combinations of these drugs that we have available that we'll discuss next time, and using the ACEs and the ARBs, I think we're going to see a lot more people getting remissions of the protein in the urine.
Now, Chelsea has a question about her creatinine level in her urine is 287. Should she be worried about that? Because what she's seeing is the normal range ends at 275.
Creatinine in the urine?
Yeah, that's what she said. In her urine is 287.
That doesn't make any sense. Okay, so there is no normal number of creatinine in the urine, and that's not to worry. That's not an issue. The creatinine, again, is a marker. The creatinine is not a pathologic marker. It's not a disease marker. The creatinine is just a marker that we use to measure your kidney function. And the creatinine in the urine, just ballpark, the amount of creatinine that you have in your urine depends upon what, James? What's the amount of creatinine that you produce every day? Depends on what,
The amount of muscle mass you have.
Yeah, excellent. Yeah. So if you are a very muscular person, you may put out 2 grams of creatinine a day. If you have little muscle, you may put 500 milligrams of creatinine a day. So it's just so the milligrams of albumin per milligram of creatinine is just a way to adjust for your the amount of creatinine you're producing. But there is no normal creatinine. Mickey, age 68, stable, GFR 4749, no protein. So yeah, is my risk of advancing? I would say that without having your full history, you're not at a high risk of developing end-stage renal disease, Mickey, because 47 to 49 is a bit low for your age, but not real low. And not having protein in the urine is a good sign. But keep your eye on it and do all the things that we've discussed over and over again. Control your risk factors, because you are still at a higher risk, even though your risk of developing end-stage kidney disease, needing dialysis and transplant is very low. You're at a bit of a higher risk of having, the heart attacks and strokes. So you want to be on a plant-based diet. You want to not smoke. You want to get your blood pressure to goal around 120, 130 systolic. Now, as far as the water intake, someone's up every 1 2 hours urinating. I'm getting the intestinal for bladder control. This is a urologic question. I don't know what OAB and CKD. OAB, James, you know what that is? I'm not sure what that is.
Okay. Do not know. Sometimes I see these and I have to Google them to figure out what they are.
Yeah, I'm not sure what we've got there. But just in general, and I'm going to do a whole show on water and dehydration and go ahead, James.
OAB, overactive bladder.
Okay. Now this is definitely a urologic condition, should they if overactive bladder, don't increase your water intake. The overactive bladder is probably due to a volume of your bladder, and that's something for your urologist to. The urologists are the docs that deal with the invasive things. They operate on the kidneys. Urologists operate. Nephrologists, we think, we prescribe medicines. Someone wants to take lisinopril 2.5. The 2.5 is a homeopathic, Sherry. 2.5 of lisinopril for protein leakage. Only my blood pressure is 110, but it's usually under 110. Now, I don't know how much protein you have, Sherry, but if you've got the significant protein in the 300 plus range, I would definitely use a higher dose of lisinopril, as high as you can tolerate. And again, with significant protein in the urine, using lisinopril 2.5 is an extremely low dose. I would go 5 or 10 at a minimum may help decrease the protein in the urine. But again, if you have very little protein in the urine, I wouldn't even bother. Blood transfusions and kidney and blood you want to avoid lesia about blood transfusions and kidney transplant. That's not on the topic tonight, but in general, we try to do minimal transfusions because that can produce sensitivity to getting kidney transplant, and that's why we use those various drugs to stimulate the bone marrow to produce the erythropoietin injections can help. Supplements. Do not take supplements, Jack. There are no supplements, in my opinion, that will help you, and they may harm you. No supplements, Jack. Not good for proteinuria. So the protein creatinine ratio, it is the urine protein to urine creatinine ratio. Deborah, that's what we're talking about. We're talking about the urine protein to urine creatinine. Not the protein creatinine in the blood. It's urine protein to urine creatinine. We call it a spot urine protein to creatinine, and your doctor will just take a tiny sample of urine and send it to the lab for both of those. Protein levels are around. Myra Gonzalez. Protein levels around 4,800. Yeah, okay. Well, if 4,800, I'm assuming it's 4.8 grams. That is significant level of protein in the urine. Okay. Over 3 grams is what they call nephrotic. That's just something that we kidney doctors use as a term. But I would use combinations of drugs, and certainly the ACEs and ARBs and some of the newer drugs, to try to get that urine protein down. Now, again, it depends on what the cause of it is. And for a lot, and we've talked about this before, many folks who have a lot of protein in the urine, your kidney doc may want to do a biopsy to see what particular type of kidney disease you've got. And there may be things to use other than the drugs we've talked about, certain immunosuppressive type drugs, which we're not going to discuss. Let's see. All right, my urine protein is 50. Okay. Speak on night.
We just got one in from David. Thank you, David, for he gave us $20 to answer his question, which is very nice. That helps support Dad Vice TV and all the streaming stuff. He says he's 35. He has high blood pressure, diabetes, and diastolic heart failure. He's stage 4 with an EGFR of 30. So he's right on that border of 3 and 4. And he's still waiting to see a nephrologist. What are your recommendations of things he should be doing while he's waiting for his nephrologist?
Well, yeah, I think that if you're diabetic and you've got, so the new drugs, we're going to talk about them next session. So you can ask your doctor about adding these new drugs for your diabetes treatment, the SGLT2 drugs, or the GLP-1s. But the SGLT2 drugs, like the gloflozins, empagliflozin, we're going to give you all those names next Dad Vice TV that I do. But those drugs not only can slow decline of kidney function, but they can also prevent death from heart disease, from the various forms of heart failure. They are so good for heart failure that the heart associations are starting to recommend them even for people without diabetes and without kidney disease. So those would be something that would be potentially of use for you. But if you're a young person, which you sound like it, that I would combine all of the things that we've got. Control your blood pressure to goal, 110 to 120. Have a relatively low protein diet, around somewhere in around 40 to 60 grams of protein today. Control your lipids, get your LDL below 60. Use the glucose control probably doesn't have a lot of effect on progression of kidney disease, but you want to try to get your diabetes in the somewhere between 7 and 8 in the A1C. And you certainly need to be on the highest dose of an ACE or an ARB that you can tolerate to decrease the protein in the urine and slow the progression of your kidney disease.
All right, Doc, that brings us to the top of the hour. It goes by so quick. Now, I want to mention your book real quick one more time. So as you guys saw, listening to Dr. Rozansky, it's calming. He knows what he's talking about. He can give you tips, things to work with your own healthcare team on to help you control, manage your kidney disease, and better understand it. And his book, if you do not have it, is Learn the Facts About Kidney Disease. Again, this is the book, in my opinion, that every kidney patient should have. If you want to, you can just go to go.dadvicetv.com/book, and that will take you directly to Dr. Rozansky's book right there on Amazon, where you can purchase your own copy for yourself, or you can check out it at your local bookstores, have them order you a copy. It's a super easy read. I just recently moved, so I don't know where mine is. It's packed, but it is so earmarked, and the spine is all white now from folding it open, talking to people about it, going back and reading different sections, looking things up. Fantastic book for anyone out there with kidney disease. We'll be back again next month for more talks with Dr. Rosansky. So thank you, Doc, for being here. And thank you, everyone out there, for being here with us today and sharing these videos and helping get them to more people out there. All right, everybody, I'll see you in the next video. Bye, everyone.